All right, welcome everyone to today's Explainer. If you are a radiation oncology resident, you are in the right place. We are taking a really high-yield, purely board-focused journey through the rapidly, and I mean rapidly, evolving landscape of breast cancer. We're going to start with some pure radiologic anatomy, build up those clinical staging frameworks you need for instant recall, and then dive into the paradigm-shifting trials that are actually driving the de-escalation of breast cancer treatment today. Look, as modern oncologists, understanding the why behind de-escalation is honestly just as vital as memorizing the what for your clinical frameworks in those upcoming exams. Let's get into it.
So here is our roadmap for today. We're going to hit 1. Anatomy and T&M staging. 2. Genetics and prognostic biology. 3. Axillary management and surgery. 4. Navigating DCIS risk options. And wrap up with 5. Paradigm-shifting radiation trials.
Okay, let's dive into this. Section 1. Anatomy and T&M staging. The rigid rules.
To target the axilla accurately, you absolutely have to know your borders. Check out the anatomic borders of the level 3 axillary nodal basin here. See that yellow outline? That's your pectoralis major. And the green outline right underneath it is the pectoralis minor. For your board exams and, frankly, just for your everyday contouring, you've got to remember that the lateral border of level 3 is strictly defined by the medial edge of that green structure, the pectoralis minor. Its superior border is where the pec minor inserts into the coracoid process. Just lock that visual right into your memory.
Now, let's translate that anatomy into clinical staging, because when you're in a completely slammed clinic or sweating it out on your boards, you need instant reflexive recall for the AJCC 8th edition clinical end staging. So use this framework. N1, just think 1 equals moves, meaning these are movable level 1 or 2 axillary nodes. N2A, think anchored. These nodes are fixed or matted down. N2B stands for breastbone, which means internal mammary nodes only, and N3C is super easy. C equals collarbone for your supraclavicular nodes.
Right, so when we shift over to pathologic N staging, the golden rule here is literally think numbers first, location second. Seriously, just count. Micrometastases up to 2 millimeters, that gives you PN1MI. 1 to 3 nodes, that's PN1A. 4 to 9 nodes, you're sitting at PN2A. And once you hit that magic number of 10 or more nodes, or if you hit level 3, boom, you've reached PN3A. If you keep the numbers isolated in your mind first, you will never miss a pathologic staging question. Moving right along to Section 2, Genetics and Prognostic Biology. Welcome to the new era. So you all already know BRCA mutations carry massive breast and ovarian cancer risks, right? That's day one stuff. But the nuanced, highly board-testable differences, those lie in what else these mutations trigger. BRCA2 actually has a slightly lower lifetime ovarian risk compared to BRCA1. But, and this is a big but, it carries a significantly higher relative association with prostate and pancreatic cancers, plus male breast cancer and even uveal melanoma. So when you see a family history that's just packed with prostate or pancreatic malignancies, your mind should immediately jump to BRCA2. And honestly, this biology fundamentally rewrites the AJCC 8th edition staging. Prognostic stage grouping takes the old anatomic T&M stage and actually adjusts it based on receptor status and grade. Notice on this table how a patient with an anatomic stage 2A tumor gets downstaged all the way to a prognostic stage 2A if and only if they have favorable grade 1 ER/PR positive biology. Conversely, that exact same anatomic stage 2A gets upstaged to 2IB if they present with aggressive grade 2 triple negative biology. The biology is literally overriding the anatomy here. It's a total paradigm shift. And this brilliantly illustrates our next point. Section 3, Axillary Management and Surgery. Less is more.
For decades, finding literally any cancer in a lymph node meant an automatic, super aggressive axillary lymph node dissection. But as our radiation and systemic therapies got better and better, we really had to ask ourselves a crucial clinical question. Can we safely omit that highly morbid dissection if we only find micrometastases in the sentinel node?
Well, the IBCSG23 trial gave us the answer, and it was a resounding yes. In early-stage patients, meaning primary tumors under 5 centimeters and sentinel node micrometastases of 2 millimeters or less, omitting the axillary dissection resulted in absolutely zero difference in disease-free or overall survival. None. But look at the morbidity stats here. By skipping that dissection, the rate of lymphedema absolutely plummeted from 13% down to just 4%. That is a massive quality of life win for the patient without sacrificing an ounce of oncologic control. In the axilla, less is truly more.
All right, let's pivot to Section 4, Navigating DCIS Risk Options. To radiate or not?
Now, what's really interesting about this slide is the sheer visual impact of omitting radiation in DCIS. This chart aggregates local recurrence rates across some of the key trials. Just look at the towering columns for the arms where patients were treated with excision alone. You've got the NSAP B17 trial showing over 31% recurrence, and the ECOG 5194 high-grade cohort creeping up near 25%. Now compare that to the dramatically suppressed recurrence rates in the adjacent bars when radiation is added in. The data visually screams at us that without radiation, a clear plateau in recurrence risk simply doesn't exist for many of these patients.
But I know what you're thinking. What about good risk DCIS? You know, small, low to intermediate grade with nice good margins. Well, the RTOG 9804 trial tested exactly this, randomizing those good risk patients to whole breast radiation versus observation alone. At 7 years out, local failure in the observation arm was 6.7%. Compare that to a practically microscopic 0.9% with radiation. So while overall survival is totally identical, radiation undeniably provides vastly superior local control, even in your absolute best-case scenarios.
So if radiation is that highly effective, do we need to push the dose even further with a tumor bed boost in DCIS? The Big 307 trial steps in here to give us our answer. For non-low risk DCIS, so we're talking younger patients, larger tumors, or higher grades, adding a 16-gray boost yields an absolute 4.4% benefit in 5-year freedom from local recurrence. It's a definitive, practice-validating number, proving that selectively escalating the dose in higher-risk DCIS really does prevent recurrences.
Let's move into our final chapter, Section 5, Paradigm-Shifting Radiation Trials. We're going to rapid fire through the major hyperfractionation trials because this is firmly the standard of care now. Delivering 40 to 42.5 gray and 15 to 16 fractions is the baseline. The UK START-B trial completely paved the way for invasive cancer, showing equal or better efficacy in cosmesis compared to the old 5 weeks of treatment. Then the DBCG hypo trial extended this firmly into the DCIS realm, again proving non-inferiority. And weighing it all confirmed that hypofractionation, even when you combine it with a hypofractionated tumor bed boost, is highly effective with excellent toxicity profiles. We are treating faster, we're treating smarter, and with way less burden to the patient. But of course, when we do need to escalate, we look straight to regional nodal irradiation. Trials like NCIC MA.20 and EORTC 2292 ask the big question: does radiating the internal mammary and supraclavicular nodes actually improve outcomes in node-positive or high-risk node-negative disease? Well, the EORTC trial showed us that at 10 and 15 years, comprehensive nodal irradiation significantly improves both disease-free survival and, this is the big one, breast cancer-specific mortality. When the biology demands it, comprehensive coverage absolutely saves lives. All right, to wrap up, I want to leave you with a final, kind of provocative thought about the future of our specialty. We just looked at the COMET trial data recently, which compared guideline concordant care directly to active monitoring for low-risk DCI. At roughly 3 years, the 2-year invasive cancer risk was 4.2% for active monitoring versus 5.9% for guideline care. That actually meets the criteria for non-inferiority. Now sure, the follow-up is still pretty short, but it begs a massive question for you all. As active surveillance protocols mature, will the next generation of radiation oncologists even be treating low-risk DCI? It's definitely something to ponder as you continue your training and ultimately shape the future of oncology. Thank you so much for joining me on this explainer. Keep studying that data, and I'll see you next time.